So today, our presenter is Dr. Deborah Lane. She is the Medical Officer for Canadian Blood Services Winnipeg Centre. She has worked in transfusion medicine for over 30 years now, and she was the 2013 recipient of the Canadian Society of Transfusion Medicine Ortho Award. So we welcome Dr. Lane.
Thanks for asking me to speak. So my talk is entitled Irradiation, the Past, the Present, and the Future. So I'm covering some history so everybody knows why do we irradiate blood, and that's to prevent transfusion-associated graft versus host disease. And graft versus host disease is often a fatal alloimmune disease after blood transfusion. And this was first described in the 1960s, and it was called runting disease. And the symptoms developed 7 to 10 days post-transfusion. And the patient developed fever, nausea, vomiting, diarrhea, which would go unrecognized because that happens with many patients with chemotherapy. But then they developed a massive erythematous maculopapular rash that may have proceeded or progressed to erythroderma, bullae, and frank desquamation. And they could also get then hepatic dysfunction and develop severe pancytopenia, so a low platelet count, anemia, low white count. So to make the diagnosis of a transfusion-associated graft versus host disease, you have to do a skin biopsy, and what they'll show on the skin biopsy is a dermal epithelial layer separation, formation of bullae, a mononuclear cell migration into the epidermis, hyperkeratosis and dyskeratosis. A bone marrow would show an empty marrow, pancytopenia, fibrosis, and lymphocyte infiltration. The liver biopsy would show eosinophils into the liver, degeneration of the small bile ducts, peripheral inflammation, and lymphocyte infiltration. If the patients went on to die and they did the post-mortem examination, what we would find is there would be donor lymphocytes infiltration in the skin, the lymph nodes, the liver, and the GI tract. So the definitive diagnosis is hard to make, but it requires serological HLA typing, DNA-based HLA class II karyotyping, karyotype analysis, restriction fragment length polymorphism analysis using probes from the HLA and non-HLA regions in the patient, genetic fingerprinting. Fibroblasts and buccal cells are required since the patient's lymphocytes are depleted, and so you can't perform normal HLA tests. And you might have to do parental samples to deduce the HLA type of the patient. So transfusion-associated graft versus host disease, the incident, we really don't have good estimates of prevalence of how often it's around. But in Japan, it's been an island that's been isolated with a single population for thousands of years, and they have a common HLA type. And they get one case of transfusion-associated graft versus host disease in 1 out of 212 transfusions. In Britain, they've had a very good surveillance program since the SHOT program, Serious Hazards of Transfusion, in UK, which has documented 13 cases since 1996, all of which were fatal. Neither Canada has great data or the US for our risks of transfusion for graft versus host disease. So our clinical indications for irradiation. So the number one is intrauterine transfusion. And why these came about was there would be a case or two in the literature of someone that developed graft versus host disease. So there are about two cases in the literature of people that got, children, babies that developed graft versus host disease after an intrauterine transfusion. And many of these cases go back to the 60s and 70s. Prematurity, congenital immunodeficiency. We do it for stem cell or marrow transplants. Exchange transfusions for hemolytic disease in the newborn. Last year we didn't do a single exchange transfusion for hemolytic disease in the newborn. Neuroblastoma, sarcoma, Hodgkin's disease with ablative chemo or radiotherapy, and any of the patients that are on fludarabine treatment. The problem for us in the blood bank is that we have a spot on the our requisition that indicates diagnosis. And most of the time, I'll have one of my cross-match staff tell me what is the usual thing that's written in diagnosis.
Low hemoglobin.
Low hemoglobin. So for us to guess any of these conditions with the number one diagnosis that's written on our requisitions, and we do have a spot to fill out whether or not irradiated or CMV negative products are required. So methods of irradiation, this is how we do it. We inactivate the T cells by damaging the nuclear DNA directly or indirectly. So what this does is prevents the donor T cells from proliferating in the recipient. And so you can do it with gamma rays or X-rays. Either one will work. And we use gamma rays that can come from either 137 cesium or 60 cobalt. And our irradiators in Canada happen to be the 137 cesium irradiators that come from NORDION. But the X-rays are generated from the interaction, and when we use X-rays, they are generated from the interaction of a beam of electrons with a metallic surface. So two of the common types of instrumentations are like a freestanding irradiator, a canister one like we use in Canada, or a linear accelerator where you produce the X-rays and you have the beam source. You can, with the linear accelerator, you flatten it, and then on a canister form, you rotate. The product is inside a canister which rotates, and then this beam of irradiation gets to all of the product while it's being irradiated. So those are the two types. So on a canister irradiator, the blood components are placed in a metal canister. Canister is on a rotating turntable, and it's rotated so that the gamma rays hit all parts of the component. What's important is this irradiator is encased in lead. When I first came, we didn't have to be in lock and key, but now they're kept under lock and key, new requirement, because nobody is allowed access to go and make a bomb from the radium. And it's very heavy. It has to be under a floor that's supported because of the amount of lead that's around it that encases it. So you can't just put an irradiator anywhere. So what components are irradiator? We irradiate all the red cells, including frozen thawed red cells, platelets that are HLA matched, because then they could look like they're identical to the patient, granulocytes, and the number of viable lymphocytes determines whether or not that unit could cause transfusion-associated graft versus host disease. So the radiation dose that we used to use 1500, and CG-wise is called a gray. It was used in the 70s, but they did subsequent studies that showed 500 grays destroyed the mixed lymphocyte culture response of isolated lymphocytes. But the later study showed that 2500 grays measured at the internal midplane was the best dose, so they had to measure it. And this was determined using a limiting dilution assay that measures the ability of the CD4, the helper, and the killer T cells, CD8 T cells, in a function assay. So they irradiated it and they made sure that the helper and killer T cells weren't going to be active. So currently the FDA recommends that the irradiation process must deliver 2500 grays to the internal midplane of a freestanding irradiation canister, and a minimum of 1500 grays to any other point in the canister. So directed donations, because there might be similarities in the HLA type, we have to irradiate those as well. But we haven't done a directed donation in about 5 or 6 years. And these may contain the lymphocytes homozygous for the HLA type or even heterozygous. It may occur when a close relative or HLA matched platelets are provided, and we therefore irradiate all the directed donations. Quality control. Like all instruments, the irradiator must be quality controlled, and a process is done to ensure each unit is irradiated must be done. We also perform dose mapping to ensure that the irradiation is performed with a simulated blood component, so that you put a component in that looks like a component, and it's radio sensitive material, so that when you irradiate it, you can make sure that the irradiation goes to all parts of the component. So our quality assurance guidelines include that the dose has to be 2500 grays. Our turntable rotation is checked daily, and we also have to correct for the radioisotope decay. If you're using cesium, it has to be annually, and if it's cobalt-60, it's quarterly. We do dose mapping once a year for cesium-137 twice a year for cobalt, and then after any kind of repair. So our confirmation of irradiation, as you're aware, we put on a RADSURE label every time we before we irradiate a unit, and if it was irradiated, the label changes color to indicate that the radiation happens. You can buy these labels that can come in 1500 or the 2500 gray levels. Irradiation isn't without dangers. Irradiation can produce reactive oxygen species that cause lipid peroxidation and membrane damage. And there can be enhanced loss of potassium from inside the cells, and large volume exchanges should have the supernatant removed, and that can either be done by washing or supernatant removal. You can spin down the plasma and take off the supernatant. There has been some controversy in the States. They're really worried about graft versus host disease, whether frozen plasma should be irradiated. And there may be a rare progenitor cell left in plasma, but we have not worried about irradiating plasma in Canada. So gamma irradiation, the part of it is we inactivate the residual white blood cells, and it reduces the risk of graft versus host disease. But there's bad to irradiation. It induces hematological and biochemical changes in the stored red cells. It accelerates the potassium leachage. It accelerates the loss of ATP, and it increases the rate of metabolism and increases the release of microparticles. And it results in a decrease in the post-transfusion viability of those red cells. So different groups out there have decided on different standards for how long you can irradiate. And we mostly go with CAP standards or the AABB standards, and that's how CSA standards are mirrored in Canada. We have AABB allows irradiation anytime up to 42 days of the unit, but you can only store a maximum 28 days post-irradiation. But in the Council of Europe, they've decided that irradiation can only happen within the first 14 days and only kept for 14 days. And the British Society of Hematology has irradiation from 0 to 14 days with a maximum of storage of 14 days. So our standards are different in North America versus Europe. So should we be concerned about the quality of irradiated red cells? And as I mentioned earlier, we use the AABB standard, even though we're CAP accredited here in Manitoba. And our products in Canada can be irradiated either at the CBS in some sites or at the hospital if they have an on-site irradiator. Irradiated products, though, aren't usually QC'd. Nobody usually picks up we don't check after the time that the unit's been produced and check how high the potassium is or how high the hemolysis. There's no known standard to do that. And it's unknown whether our current North American practice is adequately accounting for the negative quality effects of irradiation. So as we know that we've done some studies on hemolysis that occurs after irradiation, and you can see even on a regular unit that's not irradiated, hemolysis creeps up with the age of the red cell, but it also creeps up a lot faster in the case of irradiation of a red cell. This is some work that was done by some of our colleagues at Canadian Blood Service, so I won't take credit for work that I didn't do. It was done by the tech Catherine Serrano in Vancouver. And they did a study on the effective timing of gamma irradiation on hemolysis and potassium. And what happened last fall, when life hands you lemons, in October 12, there was a recognition of a breach in our SOP in donor screening with our CMV testing, which did a recall of 12 months worth of inventory collected in one CBS center, which included over 900 units of in-date red cells. So rather than just throwing out all those red cells, it was decided to make lemonade, and we did a study. And we used all those units, and that was done in Calgary. They used the units for a two-part study. 84 red cells were sent to the Acre lab for irradiation and weekly testing, and the Dr. Devine's lab irradiated the remaining 900 units to develop a matrix of collection age and storage age and impact on hemolysis. So the study design included 896 red cell units, and the matrix was designed to spread units to cover our AABB regulation time period for when you could irradiate and use units. And we didn't have any units younger than 8 days, because by the time the testing and this breach was decided and the decision made to recall these units, the youngest unit was about 8 days old. So we had units from 8 to 40 days pre-irradiation and 1 to 28 days post-irradiation. And the youngest, as I said, was the 8-day unit. So what we did was, what was done in this study is they had the weeks post-irradiation, and they irradiated the units 1 week, 2 weeks, and 3 weeks, and 4 weeks out, and had units in all these different categories. So we did the gamma irradiation at CBS using our NORDION irradiators according to our SOP, stored the unit at 2 to 6 degrees. We allowed the units to warm at room temperature, like they would be as we're transfusing them, for a minimum of 15 minutes before we sampled them. And we did 2-minute mixing of each of the unit prior to sampling to make sure it was well mixed. We did non-sterile sampling through cut tubing, and we measured the total hemoglobin, hematocrit, and the supernatant hemoglobin with a low hemoglobin HemoQ. So this is giving the percent. It's really too bad because the graph's what's important. As you go out in the weeks, this is along here, the weeks of storage. I like using the weeks of storage goes along this axis, and the weeks of storage pre-irradiation. So, and then weeks of storage post. So these are the ones that were irradiated going back on the axis coming towards you, and this is the weeks going out. But as you show, if you irradiate as a unit's been held longer, you still have higher hemolysis. Even the age of the hemolysis goes up even with the age of storage. So even if you haven't irradiated, but the irradiation goes back as you store a unit post irradiation, the hemolysis goes up. So the percent of hemolysis of gamma irradiated red cells at the end of the allowable storage. So what they did was we plotted how this mapped with all the different points of how long it was held in storage and then irradiated versus on the points on the graph. And so here are many of the cases of those would have been outside the range with AABB. But if you use the Council of Europe standards, none of the units would have had a level of hemolysis that was significant. And if you use the British Council of Standards, which are even more defined, you would have even fewer of the units that would be hemolyzed with time after irradiation. So units failing our red cell QC hemolysis standard, or hemolysis, which is our standard nationally, is a standard of 0.8%. We had 40 units that out of this almost 1,000 units that would have failed the QC for hemolysis because of the time that they were held and how many weeks post their age that they were irradiated at and how long they were held before they were utilized or in this case tested. So this is another graph to show that none of the ones using the Council of Europe would have failed the standard. But those for the AABB, there would have been some. And this is the actual data for the amount of potassium, that supernatant potassium after radiation. And it shows you that after 2 days, the potassium still is elevated, but it goes up quite significantly by 2 weeks. So within 2 weeks, after it gets to the maximum level of 60. So it is recommended by the British standards that you really should use the units as soon after they've been irradiated as possible. But you can see that within the first couple of days, potassium doesn't go up too badly. Within a week it isn't too bad, but definitely by 2 weeks it's gone into a significant level. So the summary of this research was both the time pre-irradiation and the time post-irradiation affect the percent hemolysis. And the most damaging combination seems to be 24 days at irradiation followed by post irradiation of 18 days. Our other summary of this research is that the Council of Europe irradiation guidelines would exclude most hemolysis failures, and the British Society Council and Standards of Hematology guidelines would exclude all hemolysis failures in this large data set. And what's been done is this data is being shared with the Canadian Standards Association that sets the CSA standards for what we do in Canada. And the CSTM standards are also based on the CSA standards, and we'll look at setting more stricter guidelines and standards in Canada. And increased potassium release occurs quickly after irradiations, and levels are already 2/3 of the maximum by 2 days post-irradiation. In the future, what we're looking for is pathogen inactivation. And pathogen inactivation methods using sorolins and long-wave ultraviolet irradiation combine nucleic acids by intercalation, and the UV light promotes covalent crosslinks between RNA and DNA, and this prevents replication of DNA. This may be helpful for plasma and platelets, but the density of the red cells will not maybe inhibit this use of pathogen inactivation. So key messages is irradiation is important for select groups. Irradiation has risks and should not be ordered if not indicated. And the standards should be revised in Canada and US to reflect this new data.